Now use correct posture. Stand straight, don't stoop. Stooping has an highest intradiscal pressure, so stand straight. Sit straight. How do you sit? Go back into your chair and sit. That gives you better support. Or else put a log roll just at the level of the lumbar spine to give good lumbar lordosis. That is one. Whenever you are lying down, whenever you are having backache, you can sleep like this with pillow underneath. And whenever you are working, don't bend and work. If at all you have to do this, this is wrong. Kindly get them up and then try to do it. Okay. Don't try to bend on your back. If at all you have to bend like this. Put strain on your knee joints, get down and then keep your back straight and then lift something. Don't lift it like this. You will ultimately end up in your backache, or sometimes you have to take it from the side, not even from the front. Okay. And don't do this, please do this. Usually we do this. Even if a pen has fallen down, you will do this. Okay. That causes acute backache. If you can do this from now onwards, it becomes habituation and you will not have a backache. Or else if you have a backache, it will not come back. Right. When do you have to consult an orthopedic surgeon? Not, I should say, it is specifically orthopedic surgeon. Okay. When the earlier doctor is not good enough to treat your backache, you come to an orthopedic surgeon. Or when the backache is not going, resistant backache, right, pain more after rest, that means inflammatory, or a rest pain, something going wrong, either it is inflammatory, infectious, or degenerative, or even traumatic, or even malignant. All these things can cause rest pain. And then pain with constitutional symptoms, more often infectious or inflammatory. These kind of neurological symptoms, if at all he is having, then these are the things where the patient should consult a doctor. Okay. Am I clear about backache? There is so much about backache. Actually, I have taken 3 or 4 classes for my students only on backache, but I had to finish off in only 1 hour at this session, so I had to go somewhat fast. There is so much in the backache actually, right? Just 1 minute rest. If you have any doubts, either offline or online, you are welcome, because that is the most important thing. Backache is the one most important thing usually most often we face, including me, right? That is why, how did I sit? Sit straight. Go back into your chair and sit. Next is scoliosis. I told you it is very simple. I will go fast over here, rush out. Scoliosis is an apparent lateral curvature of the spine. This is scoliosis, simple. Apparent lateral curvature of the spine with an actual deformity being a triplanar entity in AP lateral and with AP lateral and rotational components. If the spine is bent sidewards, it is scoliosis. There are various varieties of scoliosis. Okay. If you go details into that, it becomes too heavy. Scoliosis is again a big chapter. Okay. But thing is, how do you identify? You take a full length radiograph, anteroposterior view, lateral view and oblique view, and see whether the boy is still growing or not by taking a pelvis X-ray, where you can see one sign called as research sign. Research sign is nothing but a radiolucent zone over the iliac crest, which indicates an open physis. If the research sign is positive and the baby or the boy or girl is having a scoliosis, that means that the baby is growing, still have growth potential, hence the scoliosis also will increase. That means you have to intervene for that scoliosis by some means, either medical management or surgical management. Got it? Am I clear there? Research sign indicates still open physis, which indicates that the scoliosis can progress. Now, once there is a lateral bend, you have to identify when you have to intervene, either with surgery or medical management. So, you have to calculate one angle to say that this amount of scoliosis is bad and this amount of scoliosis can be accepted. How do you draw an angle? You identify this scoliosis first. What is happening? If you see one disc space, it is equal on both sides, but once there is a convexity here, the disc space is trying to open on one side and trying to close on the concave side. So, if you identify this to be the primary pathology in the spine, what spine does is the upper portion and the lower portion tries to compensate it, right? If this part of the spine tries to go that side, what happens? You usually tend to fall onto that side, but will you fall really? Body always have some compensatory mechanisms, and the superior and the inferior portion of the spine will go opposite of this one. What does it do? Going opposite of this one is it curves to the opposite side. This is a compensatory curve. So this is not the pathological problem, it is a compensatory issue. So this is the pathology. You have to identify where exactly is the pathology, and hence tackle the pathology then and there itself, not extend it too much, otherwise whole of the spine has to be fused, made into one portion so that it doesn't bend that way and this way. Okay. Now how do you identify? Now whenever there is a convexity there, the disc space on that side will be more, the disc height will be more, on the concave side the disc height will be less. Now if you go up like this, there will be one disc space which is absolutely normal. The disc space on this side and this side will be same, and once you come down, the disc space on the concave as well as convex side will be normal. That means this is the area of the pathology, and this zone are compensatory curves. Okay, this is the primary curve. And now you draw a line along this disc and line along this disc and draw perpendiculars, and the angle what you get here is called as Cobb's angle, and depending on the Cobb's angle you decide whether you have to operate or not. If you have a stable curve which is very much balanced and the skull is standing nicely balanced on this curved spine, that means it is balanced, need not operate. And if the curve is less than 30, need not operate. But sometimes if the curves are more and still they are not an indication for surgery, you go for this medical management. This is called Milwaukee brace, where you, if the spine is getting curved like this, you put an abreast hard surface over there to press it there, and then you have a corrective brace all over applied, right, going from chin to the lower end of the abdomen. Okay, this is called as Milwaukee brace. This is to support the spine. This is Boston's brace, which is usually used for lower curves, right? Milwaukee brace for higher end curves, the dorsal and cervicodorsal and dorsal-lumbar junctions most often, and Boston's brace is used for lumbar and dorsal-lumbar junctions. Okay. Now when do you want to operate for this type of scoliosis, because this bent is either cosmetic or may be causing some neurological problems. So when should you operate? When you operate when the curve is usually more than 45 degrees and still the child is having some amount of growth still present, identified by Reser's sign. Okay, just remember one thing, the curve is more than 45 degrees for you, you just operate. Okay, if I go into details you will become mad. Okay, that's why I am just giving only one part from that slide. And if it is already an adult, that means there is a Reser's sign negative, and if the curve is more than 60 degrees, then you have to operate. Simple. If the child is still growing and 45 degrees and above, operate. If it is an adult above 50 degrees, 60 degrees, you have to operate. What you are going to do by surgery? By operating. The goal is simple. The goal is to prevent any further deformity, so that there is an acute compromise of the neural canal, and you have to correct the cosmetic deformity too, and there should not be any instability in the spine. If you are running like this and walking, there is every chance that you might fall, and patient will be having mechanical backache for so long a time, because these muscles are stretched, these muscles are simply lying like that. Lot of cosmetic deformity, lot of neurological compromise coming in over a period of time. If there is an acute kink, what happens? The canal diameter decreases badly at one place and you will end up in paraplegia. To avoid those problems you have to operate. And what are the goals of surgery? To straighten the curve and orthotize the primary curve. If you can remember these two words, it is more than sufficient. That means fuse that pathological curve, fuse it. That means make it one, so that the instability is gone, whatever the kinking portion or the pressing portion on the spinal cord is there, it is also gone. So the answer is straighten the curve as much as possible and orthotize the primary curve. How do you identify the primary curve? I told you, that zone which is having straight the disc space on the either sides is normal, is the zone which is what? The pathological part. Just go one vertebra above. That means if this is the zone where it is the disc space on this side and this side is normal, here it is trying to open up. That means don't fuse this portion, just limit your fusion till here and till here. Okay, these are the stable vertebrae, so fuse these stable vertebrae to this pathological zone. How do you fuse it? Either go anteriorly and fuse, that means like this, right? Go anteriorly, put screws in the vertebral body and put a rod, or go posteriorly and fuse. This is from posterior aspect, you have put pedicle screws, sublaminar wires, rods, hooks, and then what not. This is a major complicated surgery, and then you make the curve as much straight as possible, right? If you try to meddle too much with the spinal cord, cut the bone and do all those nonsense, what will happen? Ultimately you will end up in neurological problem. So you should balance in the theatre between a permanent neurological compromise and some amount of cosmetic deformity, but this cosmetic deformity should be less than that what has warranted you to go for surgery. That means it should be less than 60 degrees in adults and less than 45 degrees in children, right? Now once you operate, all these complications can come in: neurological injury ending up in paraplegia, CSF fistulas, infection, ARDS, pulmonary embolism. Pseudoarthrosis is one of the most important reason for the hardware failure. If you depend only on the screws and rods, one fine day they will give you big hand. So don't depend on screws and rods. You have to fuse the spine. Arthrodesis is the answer. Scoliosis, arthrodize the primary pathology. Simple. That curve, primary curve which is causing the problem should be arthrodized. That should be your goal. That is fusion. The other counterpart is kyphosis. What is kyphosis? Forward bending of the spine. When will it happen? So many causes. Postural. If you are always habituated like this, ultimately you will end up in a postural kyphosis. Kyphosis, forward bending of the spine. Some are structural. Structural can come from congenital problems of formation or segmentation. If the anterior vertebral bodies are not desegmented or not formed properly and there is a bar connecting it, that is a failure of segmentation. If the anterior portion of the vertebral body is not at all formed properly, it is failure of formation. Ultimately, if the anterior portion is not formed, posterior portion is formed, there will be an acute bend and you end up in a picture like this, right? See, the anterior portion is not there properly and the posterior portion is there and the spine bends forward. You end up in a condition called as kyphosis. So this is congenital variety of formation and segmentation. This is an adolescent variety of kyphosis. It is called as Schurman's disease, where there is an end plate osteochondrosis ending up in wedging of more than 3 adjacent vertebra for more than 5 degrees and an angle more than 40 degrees. See that there should be more than 5 degrees of wedging in more than 3 vertebra, especially in the dorsal or dorsolumbar junction. This is called as adolescent or juvenile osteochondrosis, also called as Schurman's disease. Okay, this is also a kyphosis. In adults, usually tuberculosis, trauma and ankylosing spondylitis can also cause this forward bending of the spine, and in elderly more specifically you have osteoporotic vertebral fractures ending up in kyphosis. How do you treat? If it is too small, then you can brace it. If it is too much, causing a compromise more than 40 degrees, you have to operate, right? How do you operate? Either, I told you, if it is a congenital problem with a desegmented bar or there is a bar anteriorly, you have to go anteriorly, remove that segment, that bar which is causing a constriction or not allowing it to become straight. So anterior approach first, remove that anterior pathology and then come back and fuse it from posterior aspect, or else you can as well fuse anteriorly also, or you have to combine. So it all depends at what age you are doing and what is the severity of the pathology you are dealing with, right?